Ready? Just getting ready to start the show here. We're just about 30 seconds out from radio time here, so I figured we'd just, hang out, do our thing.
Yeah, start a tune maybe, something short.
Pick something nice. No, we only have like 15 seconds. So no need to start anything nice and short.
Broadcasting live from the United States of America. You're listening to the Living Sexy Radio Network, playing the sexiest music on the planet.
It's time for Stages of Life Radio with Dr. David Klein. Have a medical question? Call 407-422-1212. That's 407-422-1212 or text 23680.
Wow. Welcome to the show. Hi, guys. 407-422-1212. That's the number to call. Stages of Life Radio live. Yeah, baby. Channel that energy,
live.
Right?
Oh, yeah.
Dr. David
deep.
Klein is here. Oh, yeah. All right. So what we're going to do today, we're going to talk about headaches, facial pain, and we'll also take your calls and texts.
We could probably talk about a hangover, too, if we have to.
If we have to. He's alluding to the fact that I had a few too many whiskeys last night. I was home. I didn't drive. True story.
Really?
Yeah.
Okay, yeah.
I was home. Pretty sure I was
Not
here.
a bad thing.
All right. So anyway, how are you today, Dr. Klein?
I'm feeling pretty awesome, actually.
Really?
Yeah, it's a great day. We got our storm front through here. It's not raining, so we're not slogging it out in the water. So I'm feeling pretty good about that.
Cool.
Nice temperature out there. It just doesn't get any better.
It is nice. It is. Excuse me. So why facial pain and headaches? What's been going on,
Well, we talked about back pain last week, okay, which is good. But headache is one of the most common things that brings anybody to medical attention at all.
Okay.
So it's going to be pain or bleeding. One of those two things is what generally brings people out and about to a doctor's office. A doctor's office is by and large not the most pleasant of places to go. It's not a kind of place you want to go hang out. So when you go, it usually means something, especially for men. 2/3 of patients in the average primary care office are going to be female. 1/3 that remain are men. Why? Because men, as a general rule, don't like to show weakness, which is sort of interesting, and they're cowards. So it's the way that it goes. It takes a great deal to get a guy to go in. Women, they're a little bit more practical. They know that if things are starting to break, they better catch it while they can. Right. And men are just a little bit more difficult in that way. But headache is one of the principal, most common of all diagnoses. If you assume that headache is a diagnosis, and according to the ICD manual, it is. But it really isn't. It's a symptom. And it's pain in the head, pain in the face. Now, what can cause pain in the head and what can cause pain in the face? And they're disparate. There are many different causes. Sure. Most common, of all is probably going to be a muscle tension headache, which is a diagnosis in most clinics, in most doctors' offices, in most hospitals, is a diagnosis of exclusion. How do you know that you have a muscle tension headache? All right, we'll talk about that. Other more common sorts of headache and facial pain, sinus, very, very common cause. Mm-hmm. How do you know? Well, because you're told that it's a sinus headache, but it doesn't necessarily mean that
there are indicators.
Is. There are and there aren't. Okay, people end up with headaches for many, many reasons that don't necessarily have to be sinus. They don't have to be muscle tension. Migraine's an interesting one. Now, migraine, depending upon who you go to, is either tremendously underdiagnosed in most family practices, internal medicine offices, or it's tremendously diagnosed, which is what happens in neurology practices. So any headache of any severity at all is called a migraine if you're a neurologist. To a family doc, it's, I don't know. If you're an internist, you get a long list of possibilities, but no specifics. Headache is an enigma. It's a difficult diagnosis to make, but you don't stand a prayer of correcting the problem, controlling the issue, or feeling better unless you can narrow down the possibilities. But there are many causes of headache that you may not think of. There's somebody out there who's going, well, what about brain tumor? Okay, it's been mentioned. Okay.
Yeah.
That's the sort of thing that can happen. Most of these brain tumors that cause headache are benign, but you simply have to figure out what's going on. Could it be vascular? And the answer is absolutely. Could it be infectious? Most likely. But it could also be a number of other sorts of functional issues, like disruption of the joint that connects the jaw to the temporal bone. So TMD, sometimes known as TMJ, which is the name of the joint, not the name of the disorder, but just the same people screw that up routinely, can cause misery in the temporal side of the head.
It's horrible. I have that.
Yeah, and it's a very, very common problem. Dental issues can cause headache and facial pain. You can get headache from hypothyroidism, wouldn't you know it? Very, very common symptom in hypothyroidism. You can get headache from post-concussion, it's a possibility. You can get it actually from opiates. So you can take pain medications and get a headache. Go figure that one out. It's the same kind of thing that happens with other sorts of analgesics. It's called a rebound headache. You can get it from barbiturates, sleep medications. You can get it from getting too much sleep, too little sleep, too much caffeine, too little caffeine, too much salt or too little salt. Headache is one of those sorts of things that everybody has. About a third of the people floating around out there have headaches on a regular basis. The percentage is even greater if you look at occasional headaches. So what I'd like to do is I'm going to start with the one that people are most generally unhappy about, and that's migraine. So how many people are out there floating around with migraine? The answer, if you just decide you want to look it up, it's about 40 million people are told that they are migraineurs. How many of them really have migraine? Okay, it's probably a fraction of that. It would have to be a fraction of that, but it's going to be a smallish fraction. So just because your doctor, and I am one, okay, and just because I tell you that it's migraine doesn't necessarily mean that I'm correct. More so, just because you have migraine doesn't mean you don't have other sorts of things behind it. Because again, about 10 to 15% of people in the state of Florida, Georgia, it's probably a little bit worse because, my God, you have to have a headache to live
Georgia,
there,
yeah.
are going to have sinus headaches, allergic headaches. So an allergy, okay, is an independent process from migraine. So you can have allergy problems and migraine. You can have issues with sinusitis and migraine. They play off against each other. So just because you have a diagnosis or a label, which is all it is, for insurance purposes only, that is what's bothering you. That's what's ailing you. So what we need to do is we need to kind of refine this down a little bit. Trigeminal neuralgia causes headache and facial pain. Facial nerve, which is not a sensory nerve, okay, will cause pain, oddly enough. 11th cranial nerve injuries will cause headache and facial pain. So the list goes on and on and on and on. If I were an internist, I'd be here all day long doing nothing but giving you the differential diagnosis. Doesn't help you very much.
No.
Most of the people that are listening in right now are thinking, well, gee, I get this headache in the back of my head, and it comes and goes. It seems to follow the day after I'm doing things like hanging wallpaper, if people did that anymore, working up overhead, which they still do somewhat, or if they had their head up against a pillow sleeping on something that's a little bit too hard. And so the pain up in the upper portion of the neck. Now, the same point. Many of these people are older. Many people are younger, but they're all told very much the same thing. Well, gee, it looks like it might be due to the arthritis that you have in your neck. Well, if you're over the age of 20, okay, you're going to start developing arthritis. A lot of people younger do too after trauma, but arthropathies are very, very common in the spine. Doesn't mean that they're causing any symptoms whatsoever. So what can cause pain in the back of the head? And they're going to go, well, yeah, but I also get it behind my eyes. I get behind my eyes. It hurts really bad, so it must be migraine. And I would have to tell you that you're wrong. Okay, really, really wrong. Not a migraine, which is why you're not going to respond particularly well to triptans, to the injectables, the barbiturates, but you do so well with the anti-inflammatories, even though they do their own mischief, let's say. So there are two muscles behind the neck, behind the occipital area of the head. One's called the semispinalis, the other one's called the splenius capitis. So these two muscles go from the upper cervical area and attach to the base of the skull. They call these elevators of the head. So what does that mean? It means that if you're going to look up a little bit, look down a little bit, look from side to side, these muscles are under tension. So when the attachment becomes inflamed, either due to compression trauma, stretch trauma, blunt trauma, or just simple wear and tear, those little attachments on the bone become inflamed. There's a nerve or two in there. One has a name called the greater occipital, a second one called the lesser occipital, and a host of smaller branches that can become irritated and cause headache that goes behind your eye. So what we're going to do is we're going to allow ourselves a few minutes to pay the bills, Then we're going to come back and we're going to continue our little discussion on what might be causing your headache. And it's not just your spouse or kids.
No, or the weather, like you said.
Or some combination thereof.
Yeah, it can all be that. Barometric pressure gets to me.
Yeah,
that and whiskey. We won't be doing
as long as it's good
anymore.
whiskey. It's good whiskey, it's okay.
It was okay. It was crap. We're going to take a quick break. Line up on the phone if you've got questions. 407-422-1212. We already have some texts coming in at 23680. And, of course, we're live on social media. You can ask your questions there as well. You are listening to Stages of Life Radio on News Radio WFLA, Orlando. Yeah, so, you got a bunch there. Let's see, Lance said that he gets headaches often, migraines about every other month, and when his whiskey level gets too low, he gets headaches too.
There we go.
Thanks for playing along with the home game there.
Yeah, so what is it about whiskey? What is it about alcohol that causes headaches?
Sugar.
Well, actually, it isn't. It's an enzyme called acetaldehyde, or it's a product called acetaldehyde from alcohol dehydrogenase, which is the enzyme. So alcohol has to be metabolized, okay, so it gets chewed up. It's a carbohydrate. So this particular enzyme creates a substance that is really, really irritating to the brain. And wouldn't you know, it causes headache, it causes some nausea, it causes its issues. So how do you deal with migraine now that we're on the topic of
headaches?
Of hangover headache? And I usually reserve this discussion to our shows before and after New Year's, before and after Christmas, and before and after my birthday.
Show, right?
Yeah. And so what you do is you try really hard to flush out the acetaldehyde, and you do that with water. So if you can get loaded, not with the alcohol as much as with water, you will urinate it out. You'll pee it out. Or sweat it out.
I've been sweating it out for...
The other thing, which is even more interesting, is a substance called dimethylglycine. Now, dimethylglycine, if taken before you rack out at night, so if you're in the military, that means the rest of you go to sleep.
Yeah, hit the rack.
Hit the rack. So you're drinking a great deal. You know it's going to be a long day. So what do? You load up with the water, which means you'll probably be getting up to pee a couple times. That's all right.
That's all right.
But the dimethylglycine, you load up with about 2.5 grams. That's 5 tablets of dimethylglycine. We have a product called Game On. Now, how did I come up with Game On?
Game On.
Game On. It came up with, Game On dimethylglycine was being worked on as a treatment for Alzheimer's disease. Okay, because it's a substance that will give the brain tissue energy without having to have blood or oxygen present. Really, it's kind of cool.
That is kind of neat.
Very, very interesting. So I started using it to try to figure out what it was useful for. Well, I used it on myself, didn't really notice anything. Some of the people I gave it to found that it helped them when they were studying. So it's a substitute to some extent for things like amphetamines. However, the most interesting use was that it blocked hangovers. So, I took the stuff out to New York. I was up there trying to market it to some folks, and so we went out partying. Now, these are accomplished drinkers, which I am not. Took the stuff along. Those three of us that were in my party, we all did our dimethylglycine and drank these New Yorkers under the table without incident or hangover.
Nice.
We came up with a name and called it Game On, which is short for Game On. Yeah.
Stand by.
And we kicked their butts in terms of the finance. It was great.
Welcome back. Stages of Life Radio, Sunday afternoons from 4 until 5 p.m. We also podcast the show and videotape them so you can watch them on social media and get a peek at the doc. What?
Oh, yeah. I don't look like that. Yes, I do. No, I don't. Actually, I'm just a meme. You just don't know it.
He is. He's
a
a meme.
really good graphics artist.
Okay, so as luck would have it, Doc channeled into what was going on over here and texted me about an hour ago. So let's talk about headaches.
Like your headache.
Like my headache. Well, no. This is a full-on hangover. We've got the sweating it out. I've drunk at least 2 gallons of water. So, but anyway, normal headaches.
Yeah, normal headaches. So we'll finish up about the muscle tension headaches. Mm-hmm. This one in particular is a really, really cool one, but it's splenius capitis tendinitis. And so it'll pinch a nerve called the greater occipital nerve, which causes referred pain behind the eye, or both eyes if you have it on both sides. So it gets misdiagnosed as migraine as a result of this. So a lot of time is lost, a lot of misery. And the way that you deal with this, okay, is very different from the way that you treat migraine. So I have people that have come in that are just want to scream. They want to dig their eyeballs out. It hurts so badly. And so you go ahead and inject a little bit of local anesthetic, okay, and a little bit of a steroid if you have to, right between where those two muscles attach at the base of the skull. And about 30 seconds later, the headache is gone. It's impressive. You know, if you go in with a very, very thin, very skinny needle, it doesn't cause any bruising or much bruising, if any. And, you know, the headache just melts away. So the first patient I had with this was, I think, in her 80s, and she'd had headaches since she was a teenager, had fallen off a horse, struck her head on a fence, and had constant headache ever since. And so she came into my clinic and asked me whether I could help her. And I thought, well, okay, we're looking at a 68-year history of headache, daily continuous headache. And so I told her I didn't know, but I would do the best I could. No guarantees. The only guarantee I'll give you is that I will do the best that I can. So I said, give me about 10 minutes. So I saw another patient and took care of problems. And came back and said, okay, I got something I want to try. And so what I did was I pretended in my own mind that I was a structural issue. And I just marched my way through the anatomy, just trying to sort through how it would present. And what I came up with was an inflammation of this attachment, pinching that nerve. So it wasn't in the literature before this. This was 1984, 85, I think, when I first wrote this article. And so, I asked her, I said, would you like me to try something? She goes, try whatever you want. Okay. So I went ahead and injected it and waited and waited and waited a few minutes altogether. And I'm thinking, okay, that's plenty of time. So I asked her, I said, ma'am, okay, how do you feel? And she goes, well, I don't know. So I was a little taken back. I asked her, so what isn't there to know? She goes, well, are you having any pain? She goes, I don't know. Why don't you know? She goes, I've never experienced anything but pain. I don't know what I'm feeling right now. So I was actually humbled, a little bit humiliated, but I learned something that day, okay, which is that the perception of pain is every bit what Descartes had to say about it, which is it's a little different for everybody, and it's really hard to nail it down. So this lady, I was able to break up a headache that she'd had her entire adult life and much of her adolescence. And we did it with 2 or 3 injections of steroid, and last I heard, she was probably passed away because this was a long time ago. However, she did really, really well. She was in my fan club for a long time.
I'll bet.
But this is a very cool type of headache. So if you want to go looking this one up, and I encourage you to do so, look up greater occipital neuralgia, because that's the one that people now. Greater occipital neuralgia has been identified for years, but the inflammation at this point hadn't been. Now, why does it make a difference? Because when you're the person that's trying to put the fire out, it's really nice to know where to aim the hose. Because you're going in with very, very, very fine needles, small volumes of medication, because it's the only way that you're really going to be able to nail this thing. So if you shotgun it or machine gun it, as some of these guys do, it really doesn't do anybody any favors, and you overload the patient with the medications. So splenius capitis fibromyalgia, greater occipital neuralgia, pretty much the same thing. Probably the single most common cause of headache in my medical practice. Number 2 is trigeminal neuralgia. Now, mind you, this is not migraine, right? So number 1 and number 2 are not migraine. So neurologists, they're 93 to 95% are migraine. No, I just knocked off about 45%. Okay, another 30% is trigeminal neuralgia. That takes us to 75% roughly. And so the trigeminal nerve, from its name, if you've any education, okay, in Greek or Latin, okay, tri means 3. Okay, so the trigeminal means that it has 3 origins. And so, the 3, supraorbital, infraorbital, and mandibular nerves, 3rd division. So these 3 branches emerge on the face. Now, every dentist has spent at least the first 2 months of their dental school learning about the trigeminal nerve. Because when you go ahead and you numb up people's teeth, you focus on that 3rd division. That is all about the 3rd division. Okay, to some extent, the better ones learn about the 2nd division, but they never teach about the real 3rd division. Okay, now the real 3rd division isn't the one that, goes out to your teeth. It goes up the side of your head. 1/3 of that nerve. This comes as a surprise to most docs that have, that are out in practice. 1/3 of that division goes up the side of the head, and that's where it gets nailed. So when you have TMD/TMJ disorder, the masseter and temporalis muscles, they attach at the angle of the mandible, go up the side of the head, and attach in what you would see as that muscle that goes underneath your eyeglasses. Okay, and that nerve travels up the side of the head. So when you grit your teeth funny, or if that area is in some way inflamed, or if that joint is aggravated, that little nerve, which is all of about 3 to 4 millimeters away from that joint, gets put upon, and it causes pain up the side of the head, and will also cause dental pain, that people will go into the dentist looking for the pain in their teeth. They can't find it, and many of these folks end up with root canals, extractions, and dentures to try to feed a nerve problem that was really not even inside the jaw.
Oh, my God.
So we treat that, and I used to treat that with an injection also. Why? Because I was a needle jock, and, when I used to do this stuff. Lots and lots of nerve blocks. So I found an easier way, and a much less aggravating way, and actually a whole lot cheaper way to treat it, and that's using transdermals. So this one I treat with a transdermal form of Neurontin or gabapentin. A lot of listeners have taken gabapentin as tablets, but they've never seen it as a salve. It's because I invented it.
Oh.
Okay, so it's it's not we. Another group produces it locally. I don't get 10 cents for it. I write the prescription, it gets used, and it knocks it out without the need of a sharp end of a needle. Very, very cool problem. So with it's called the Trego branch of the third division trigeminal nerve. It's just a little tiny nothing, but it goes into the external auditory meatus of the ear. So when people come in with this particular problem, many of them will go, it's funny, but I have pains in my ear. If I could just dig something out, it would feel better. If I scratched it out of there, I would feel a whole lot better. That's your third division trigeminal, auriculotemporal neuralgia, most common cause of trigeminal neuralgia. Infraorbital, a little bit less so. First division goes over the eye, and it gets damaged in things like automobile accidents and pugilistic injuries. That means somebody struck you with a fist.
The sweet science.
Yeah, okay. So, it's just the way these sorts of things. So I see these with domestic injuries, where you fall down or hit a cabinet that was really somebody's fist.
Oh.
So each of these things is treated a little bit differently. So it's really important that you refine it. And you need to tell the doc kind of what happened. Nobody wants to hear about how you were struck. So what you want to do, so that you don't bring in the authorities, is you simply lie about who hit you. You know what I mean? This is the way these things go. But nobody believes it was a cabinet or a doorknob. What other sorts of headaches are we looking at? So that knocks out about 75% of the headache practice that I've got. Those two diagnoses. Okay, so number 3 is going to be sinus. Now, whoa, wait a second here. Where's migraine?
Which is actually part of what's going on today. I got a sinus headache.
So the sinus, okay, and you don't have just those sinuses under your eye.
No.
You have dozens of sinuses all over the front part of your face. You have them in the center of your head, okay, dead smack in the center. Just the way these things go. And you also have them behind your ear. Okay, so the mastoids used to be I don't know. It was one of these sorts of things that one of the most common surgeries that was performed prior to about 1960 were mastoidectomies. So people would end up with these terrible mastoid issues. They'd have them chopped and chiseled out. I mean, it's the surgery. So, when I did my surgical training back in early 1980s, we were still doing it, but rarely. But when you did a mastoidectomy, you actually just about removed somebody's ear. You took the ear out. It's kind of like removing somebody's air cleaner from their car. Okay, the thing pops out, you chisel away at the bone, clean it out, and then put the ear back on. And, the surgery was remarkably disgusting. The recovery, though, was actually pretty good. So when these sinuses get infected, it's like getting an infected abscess. They have to be drained. They have to be cleaned out. And so when the sinus doesn't have much of an opening, it's really, really hard to clean it out. So the mastoids, when they get infected, are a disaster. So when I have people coming in with certain types of headache in the upper neck and in the ear, I always look at the mastoid, make sure that I'm not missing something common or something that used to be real common. What sinuses are more commonly involved, we'll discuss momentarily. And then we're going to start at the top. Adenoids are outside. We'll start at the top, work our way down, and then we'll answer some questions on the air.
Again, get on the line if you like, 407-422-1212, 407-422-1212. Don't be shy.
And this is the Headache Network.
Yeah, the Headache Network today. 23680 is the text line, and we are live on social media. Just look for Stages of Life Medical Institute. By the way, any products that he's referenced, you can find in the doc's shop. Just go to stagesoflifevitamins.com. We'll be right back. Yay.
All good. It is good to be
I'm actually
breathing.
Really stuffed up.
Yeah, you sound a little rough.
Well, I'm all right.
Was it worth it? Yeah.
Probably.
Yeah.
Yeah.
Yeah, it's always worth it. You have to say that. Otherwise.
It was. Yeah, otherwise it'd be like, what are you doing?
Exactly.
I suppose. So anyway, let's see what here we got. And says, explains, I was 19 in a bad car wreck, shattered my face, my left cheek, and orbit are titanium. Also been in the martial arts and was a bouncer. A lot of head hits.
Okay. Now, so when did they stop hitting? Why would you allow that?
Why?
Okay. So when somebody has a facial fracture set up like that, and I was in the martial arts also for a good long time, it's not uncommon to be struck in the face. The place that you're likely to get hurt is going to be the nose. So we're going to discount that because, after all, you look funny. You look funny before, you look funnier now. But the one that gets nailed is the one in the zygoma. So that's the arch that goes underneath the eye. So if you were popped in the eye, and you had facial fractures, that's probably where it occurred. There's a little tiny hole there, okay, where the second division, the trigeminal, comes through, and that gets injured, pugilistically. So it could be, car accident, but being slugged, okay, in the face is a good one, or being elbowed. So, when I used to I never was a bouncer, okay, I just didn't think that was a good occupation. But when I've been thrown out,
they're not so careful.
No, I did full contact karate for a couple of years, and so what you do is you can use, strikes to the face. Whether it's with a palm, whether it's with a fist, or whether it's an elbow or knee, and it can break that bone. It's not that strong. Yeah. Okay, the jaw is a whole lot easier to break. I've done that. That's if you smack them from the side, they're actually quite easy to break. Yeah, but when you crush. When you crush the anterior portion of the face, you can pinch that second division, and that can be a real son of a gun to get through. But the topicals knock it out for about 12 hours.
I got punched in the eye when I was robbed as a Burger King manager.
You're close. Okay, one finger breadth under where you just poked.
Yeah, and that's broken there.
That chipped. Okay.
Socket.
Yeah.
So yes, I constantly have eye pain in this eye because of that.
Yeah. Here's looking at you.
Yeah, was it worth the burger, kid? Welcome back to Stages of Life Radio. We do this Sunday afternoons because, frankly, somebody needs to. I mean, today we're talking
We're stepping up to the plate.
Yeah, we got this. Any products referenced like Game On? People are asking about Game On.
Game On.
StagesOfLifeVitamins.com.
Yeah, and Game On is very interesting. If you decide you want to use it, send me a text because the instructions are very specific as to what you're going to be doing with it.
Okay.
And it's not on the box, but I'll be happy to share it with you. I'd have to share it with you.
We were talking about the sinuses and that they're all over the face and that they can cause problems, but
the most common sinus to get scrambled, okay, is the maxillary. So this is right underneath your eye. So if you looked at somebody in the eye and dropped it vertical down about 3 inches, it'll point you right to the maxillary sinus. And you have 2 of them. What's interesting about them is that they drain kind of like a teapot. You're going, okay, well, what's he talking about? Okay, I want you to imagine a second that you're holding a teapot. A little teapot shortens down. You look at the teapot. So when you tilt to one side, okay, or the other side, backwards or forwards, the tea is going to be expressed through that spout. So when you have maxillary sinusitis, it'll drain when you're going to bed. Okay, why? Because as you rest your head backwards, it'll drain through those ostia. All 3. There are 3 of them that'll drain. Okay, they'll all drain at one time. When you lean forward, they may drain even more. As long as your sinuses are draining, it means that ostia or hole is open. As long as it's open, everybody's happy. You may feel a bit full in there, you may feel a little pressure, but pain doesn't usually happen. But if any one of those 6 ostia start to seal up, pressure will start to build up, fluid starts to accumulate, and then you start getting sick. So what do you do? Okay, if somebody has a sinus headache.
Not the neti pot.
Nope. No, you don't want to be pushing infection back into your head. That's a big mistake. So what is typically done is people take antihistamines because they think, it must be allergic, which dries everything out, which is exactly what you don't want to do because you want to drain it. You don't thicken something. If you have a honey bear and you want to get the honey out, you want to make the honey liquid, not hard. So you don't put it in the freezer. You put it in something hot so it gets thin. So when you take an antihistamine, the mucus gets thick. It really buggers things up. So it's long been known that when people have colds, upper respiratory tract infections, when they take antihistamines, the symptoms last longer.
Yeah.
You did yourself a big
Drug it
favor.
out.
Yeah, you dried it up. Good idea. So you might be able to fly. You might be able to do different things that are avocationally necessary, but you're going to have symptoms longer. The disease will last longer. So when I was a flight surgeon, okay, we used to use Afrin when people had these sorts of headaches or sinus issues. Otherwise, you have to knock them out of flight status, something called deniffing them. Duties not to include flying. So you spray Afrin into the nose, each nostril, and it would shrink the mucous membranes back so that the sinuses would drain. So a lot of pilots, okay, will to this day still fly with Afrin because you're stuck in Mumbai airport and you need to go someplace. If you have a sinus blockage, the last thing you want to do is fly.
You do not want to get that pressure.
You don't want to get that drop in pressure, something called barotitis media, something that makes people miserable. Okay, so that's the largest sinus system, but it's not the one that causes the greatest misery. Just over your eye are the frontal sinuses. They drain even more horribly. So when they get buggered up, okay, you can have lifelong problems. So there's some things we'll talk about how you can deal with it. But my single favorite ones are the ethmoid and sphenoid sinuses because these are the ones that defy diagnosis. The amount of mucus that's contained within these sinuses is less than a thimbleful. I mean, much less than a thimbleful. So these sinuses sit on the inside of your head, okay? And when you start having these issues, this is where people end up with swimmy head. They'll end up with weird sorts of symptoms, visual changes, ataxia, all kinds of crazy symptoms. And 10 years down the line, somebody decides to get an MRI and actually look at those sinuses. You have to look specifically for them. And then, boom, you find yourself with an ethmoid or a sphenoid sinus issue. And so then, you're on a good, lengthy treatment protocol, for thinning out the secretions. And then you take care of it, and that's the end of it. It's kind of cool. Cool problem. So now we're talking about 85 to 90% of headaches. Yep. We're not going to talk about 11th cranial neuralgia, Eagle syndrome. We're not going to necessarily talk about parathyroid adenoma. We're not going to talk about, prolactin secreting tumor. Now, all those things take up less than 1% collectively, but the remainder is mostly going to be a non-trauma. So if it's not post-concussion, it's going to be migrainoid. Now, does migraine mean that you have severe headache? And the answer is, of course, no, because otherwise I wouldn't have asked the question. So a severe headache isn't necessarily migraine, and you can have migraine with no headache, especially in kids. So kids that have gastrointestinal problems, losing time at work, unpredictable, they have to be evaluated for something called acephalgic or abdominal migraine. Very, very cool problem. Now, why do I care about this? I've seen it over and over and over the years, but it's one of the most common causes of regular time lost from work. And they'll say, well, gee, abdominal migraine is only present in children. Something that's another bit of nonsense. Okay, it can happen at any age. But in children, they don't know how to articulate what is going on. So it's very much like doing veterinary medicine. Okay, why don't you ask your dog why it's feeling punk? Okay, well, dogs go, babies cry. That's the only word they know. And children are blessed with a bigger vocabulary, sometimes vulgar, I found, but they don't know how to express vague symptoms. They don't
feel well.
They're just not with it. So, abdominal pain, vague abdominal pain, nausea, doesn't seem to really roll with any particular dietary issue. You're going to think, well, it's irritable bowel. Well, little Mary there, it must be, gynecological. Well, wait a second here. She's only 5. I rather doubt it. You know what I mean? So, you have to look at the whole situation, but you can have this thing for decades before you really have any headache with it. It's kind of cool. So migraine is something you have to consider, not just because you have a headache, but even if you don't have a headache. Acephalgic migraine, vestibular migraine is really more. You'll feel vertigo, vertigo, nausea, vomiting, positional, and it's treated a little bit differently than the other migraines. But these days, it's not that different. So, what are the sorts of things with classical migraines? You say, well, classical migraine. Little bit of insight, 42 years of a practice as being a practicing physician in private practice. When somebody uses the word classical, it simply means that it's got all the really cool symptoms, but it's probably the rarest of all presentations. So when I was in medical school, when somebody a patient had a problem that was in any way classical anything, you would see these people with white coats just billowing behind them, marvelously cool. If you were taking photographs of this, running down the hall so they could see these people before they got healthy enough to be discharged, so they could see the classical rash, so they could see the classical this or the classical that. So classical anything is the rarest presentation. So classical migraine with aura means that you end up with these funny looking spots before your eyes, but it could be smells, it could be sounds, it could be thoughts, it could be colors, it could be any number of different things. As the blood vessels in your brain, the meningeal arteries, little tiny ones, start to go into spasm, is when you start seeing these sorts of symptoms, and they dilate when you get the headache. So that's the classical presentation of migraine. But some people, they'll end up with migraine only when they're having their menstrual period. Or they'll only get their migraine when their wife is having the menstrual period. It's almost contagious, it seems.
It's a little different, I think.
Yeah, it's a little different. But the stress of it can do it. But there's a trigeminal nerve trigger to migraine. And this is where it gets to be fun. All I have is trigeminal neuralgia. How do you know I have migraine? Well, because you can have both. And this is where you can, should, and probably do. So when you're treating migraine, and when you're doing a good job doing it, it's just not a matter of giving somebody an injectable CGRP or an oral or sublingual CGRP, latest thing out there right now. It's called expensive treatment of migraine. But you also want to be giving them anticonvulsants, things that make that nerve settle down. My favorite's baclofen. Why? Because it's cheap, it's easy, and helps you sleep at night. And the only side effect of it is it makes you sleepy at night when you're trying to go to sleep. So it's really not that big a deal. And it's cheap. But the CGRPs, the triptans, the CGRPs are a whole lot safer, it seems, than the triptans. Triptans can cause heart attack. They can cause esophageal issues. They can cause all kinds of problems. And, they only last really a day or two, if that. Whereas the CGRPs, we're talking about these injections, which we do a bunch of at the office. You figure out whether it works. If it does, you send people home with a prescription for it. And they can do self-injections with these automated injectors like we had in the military. So if you think you're going to die from sarin gas exposure, you go and get your little injector and you stick it in your thigh. Yeah. Even the sissies that didn't think they could do it find up the strength when they think they're going to be dying in convulsions. So the CGRP injectors. So let's say we do in fact have patients that just can't do it. So they come in, they sit down, and we do the injections for them because we're sweet.
That is sweet. That is sweet. We had a lot going on our text line and on social media.
Let's grab a few of those because I don't really feel like talking about post-concussion headache right now.
Okay. Kathy's checking in from Nantucket, says, hi, Dr. Klein.
Hey.
Hi, Melissa. Sarah Grace wants to know some thoughts on the new Pfizer and Merck COVID pills.
Okay, well, here's my thought on it. Okay, so they're going to be expensive. Okay, but they're not advertising with us, so we're not going to promote them. But after this, we'll go over the pills.
We'll spend a few minutes
we'll give them a little bit of time.
Talk about all that. All right, this is Stages of Life Radio. We do the Sunday afternoons. The phones are wide open, 407-422-1212. And the text line's got a few texts on it as well. You want to contribute to 3680. That's our text line number. We got one last segment here. So what you looking for? Looking at the art?
Yeah, I was just looking around. She reorganized the room here.
Yeah, I redid the studio.
She cleaned it
yesterday. And then I got drunk. Yeah.
Well, I can see it.
I didn't do it when I was doing this. This was a morning thing. I did this almost all day to yesterday, rewired the entire studio. But there you have it. Okay, so Sarah, why wouldn't the COVID pills be free like the vax?
Okay.
Good question.
Because nothing is free. All right? So now that we're no longer in a position where we have to go running around getting treatment, ask the people that have been receiving hospitalizations for COVID if it's free.
Oh, my God.
It's not. Ask the folks that got the monoclonal antibodies what their copay was in on. Okay, it's expensive stuff. So if you have COVID, so you come down with COVID, okay, the pills will be available to you at the pharmacy, okay, for a fee. Okay, whether your insurance covers it or not, that's where it's going to start getting interesting.
Yeah.
But it's only going to be available if you get sick with COVID. Now, does that necessarily change the fact that you're going to be out of commission for 2 weeks? No, it doesn't change it one bit. All right? It doesn't make any sense. So, The same thing is true for all the other treatments of COVID. There are two things that I know about that are helpful for prevention of COVID, and one is called lactoferrin, and the other one is called N-acetylcysteine. And there are going to be people out there going, "Well, I've never heard of that. I've never heard of that." Okay, well, I'll tell you what. Okay, N-acetylcysteine. Look up acetylcysteine on PubMed, PubMed.gov. That's the National Library of Medicine, and you're going to see 75 articles published on using N-acetylcysteine as an adjunct to prevent death, basically, but also to prevent getting the disease at all. The other one's called lactoferrin, and both of these are over-the-counter products. We have both of them at Stages of Life, and we've been using them both. And if you don't believe that the N-acetylcysteine is marvelous stuff, try to buy it on Amazon now.
Huh.
NAC is the abbreviation. See if they have it, because they pulled it off, those gentlemen and gentlewomen, because after all, there's a political need and demand. So, what do I think? So,
equity, I believe.
Yeah. So as far as them coming down with another pill, that's not the only pill that's on the market for it. So, marvelous. Get the vaccine.
Yeah, it's a better bet.
It's a better bet. And then if you do get sick when you've had the vaccine, get the hydroxychloroquine, sometimes known as Plaquenil. Plaquenil's been around for over 50 years. And Plaquenil works. I took it. My wife took it. It was remarkable. 30 minutes after you take that stuff, you go from feeling like death to feeling pretty darn good. Lasts about 12 hours.
Yeah.
Then you take another one.
Oh.
And it's cheap. It's like $12 a month.
Yeah, that's pretty inexpensive.
Yeah, I think anybody can.
Welcome back at Stages of Life Radio. It's our last segment with you. We are live, 407-422-1212. The question we had on our social media was about the EUA vax continuing to be distributed and the pills that they've been
which are also going to be EUA. So understand that the monoclonal antibodies that everybody goes, well, I don't want to take the injection because it's experimental. Well, for starters, they got their authorization. That's number one.
Yeah.
Okay. Number two, the monoclonal antibodies are on an EUA. The same thing is true of these pills that just came out. They get an emergency use authorization.
These will cost you.
If you're going to be hypocritical, at least be honest about it. Okay. So if you don't want to get the shot because you're afraid, that's fine. Okay, but it may cost your job.
Yeah.
Okay, it would cost me mine. Okay, so I would not be able to be in my office if I didn't have to take it by law. I took it because it was the right thing to do. All right, but if I didn't, then I wouldn't be there. We would have to close up. Yes. So there are a lot of people out there that are having to quite literally roll up their sleeves to keep the country going. And if you don't want to, it's going to come at a personal cost. But these pills and whatnot, they're not going to do much for you.
No.
And even the hospitals. So somebody goes in the hospital. You don't think that they're using monoclonal antibodies when they have people in the intensive care unit?
Yeah, they are.
Yeah, they are.
All right, let's go to the text line. My vitamin D level is 51.7, taking 5,000 IUs of vitamin D. Do I need to increase the dose?
No, actually, that's a perfect level. 50 to 80 is where it's a sweet spot. So, no, you're doing just beautifully. If you want to increase the level a little bit, take your vitamin D with a fish oil or an evening primrose oil or a borage oil. Vitamin D is a steroidal hormone, and it's miscible, it's soluble in oil. So your stomach acid is in a liquid. It's water-based. So if you take the pill with an oil, it'll enhance the absorption. So the level is good. Don't increase the amount, but if you want to tweak it a little bit, take it with a fish oil.
Makes sense. We started the show talking about headache and facial pains. This person wants you to talk about Bell's palsy.
Cool. Bell's palsy is... it's a weakness. It's a destruction of the facial nerve or a branch of the facial nerve. So the facial nerve has 7 divisions, and they're all motor. So when one or more of these things gets either infected or if the body has an autoimmune response to it, you'll end up seeing a facial droop. What's neat about that is that if you're really good about noticing this in people, and if you have a family member that has this and you're watching television, there are at least a half a dozen talking heads, news types that have had Bell's palsy. Very common problem. So when you develop Bell's palsy, what do you start thinking about? Okay, first thing you should start thinking about making sure that you don't have some type of viral vestibulitis. So how do you treat it? It's generally treated with a string of prednisone tablets. I'm not so sure that that's necessarily the best way to do it, but topical B12 is actually something you can have made and can be applied topically and enhances the recovery on it.
I see a steroid working.
Well, it can, because if it's a viral vestibulitis with a Bell's palsy, sometimes it does.
Okay.
So more times than not, you'll never figure out what caused it. So now I've got one patient, really gorgeous girl, and so she's got Bell's palsy. And so what we did was we sent her to Harvard. Actually, there's a plastic surgeon up there that was doing Botox to certain muscles in her face to even it out, so it looked okay. And they've done a beautiful job with it. Yeah. Okay, but I wouldn't trust anybody in this area to do that.
No.
And I do Botox, and I won't touch it.
How do we know if an abnormal EKG might be due to the vaccine? Is there a test?
No, there's no test that you can do other than something like interleukin-6 or an IL-6 would be helpful. A CRP would be helpful. So if the IL-6 is elevated, then it looks like it could possibly be COVID. That can happen. The CRP is much less sensitive. The problem with the IL-6 is that when it's done at Quest, they don't seem to ever come up with a number. I've sent a bunch out there because the patients have that insurance. So we've done a bunch of IL-6s. We started doing them about a year ago. So the big commercial labs started maybe several months ago. So I don't think that they really understand how to get those standards done right.
Well,
but interleukin-6 is what I use. So if you have an elevated, or whoever this person has an elevated IL-6, that's what you'll look at. How do you deal with these EKG issues? That's the better question. So what I generally do is I go ahead and hit people with CoQ10. Why CoQ10? It's drawing from the hip. There are problems with things like AFib that are treatable with CoQ10. There are pathologies of the heart that come from statins, which is sort of an interesting problem, that are treatable with CoQ10. Angina, in Europe, they use coenzyme Q10 as a primary treatment for angina. So it's worth doing. The second thing is a medication called DHA, or docosahexaenoic acid. It's a part of fish oil. And what it does is it's necessary to regenerate the nervous tissue that's been damaged. So could it be post-COVID? The answer is yes, depending upon what you're talking about.
Right.
Okay, there are lots of EKG changes you can see, but I've got 2 patients in the practice that have congestive heart failure following COVID, but not the vaccine.
Yeah.
All right, not the vaccine.
No.
The question was very specific about the vaccine.
Right. No,
so,
but COVID, I'm seeing effects. I'm seeing people who have had effects at heart situation.
Yeah. Well,
like reminiscent of rheumatic fever type of results.
Rheumatic fever is different. Rheumatic fever is an autoimmune disorder involving the heart leaflets, the valve leaflets, right. Whereas the COVID business is all vascular. So when somebody comes in...
the muscles?
No, it's the vasculature of blood vessels.
Oh.
So when people come in with these sorts of cardiac issues, the first thing that I do is I start them on anti-inflammatories. My favorite anti-inflammatory for this is Plaquenil or hydroxychloroquine. Okay, we use it for rheumatoid arthritis. We use it for scleroderma. We use it for, just a host of these autoimmune disorders. And that is probably what this is all about, is that there's a shared antigen, between, COVID, and the heart muscle or the heart vasculature.
That makes sense.
But I'll tell you where I'm seeing a lot of problems, but not so much after the vaccine, although I'll have a better opinion on this in about 6 months,
right.
Is with kidney issues. You'll see drops in EGFR. So you have to be real careful about looking at, many of these problems. But when people get sick with COVID, it's far more common. You end up with about a third of people that get COVID the good old-fashioned way that will end up with cardiac issues, congestive heart failure, rhythm changes and whatnot.
Very much so.
Yeah, it gets to be a lot of fun in the diagnostics.
It does. 60-year-old woman, well-managed diabetes, several years, 80 to 90s in the sugar in the morning.
Good.
5.4 A1C. After receiving fiber booster, sugar went up to 150 to 170 and has been almost a month now. I've read articles about this unusual reaction. Any input? And we only have about a minute.
Okay, same thing. Okay, if you end up with a vasculitis, inflammation, first thing you want to do is cut back, as you already have in your sugar. The hydroxychloroquine would be important. The lactoferrin-containing colostrum and acetylcysteine would be the place I would start with it.
There you go.
Yeah, and I've seen that before.
We're seeing this. All right, so Dr. Klein's office is open Monday through Friday. You can always find him online, too, stagesoflifemedicalinstitute.com. And you can bounce off of that site to just about anywhere with
It's a good
vitamins,
site.
the radio, all that. We'll see you next week. Say goodbye, Doc.
Have a good one.
You've been listening to Stages of Life Radio with Dr. David Klein. Check out stagesoflifemedicalinstitute.com or stop by 1917 Booth Circle in Longwood near the intersection of I-4 and 434. Call 407-679-3337. That's 407-679-3337. Dr. Klein accepts many insurances and Medicare too. Join us next Sunday at 4 p.m. on News Radio WFLA Orlando.